Welcome to our Heart Health Lecture Series. Thank you for joining us. Next slide. I'm Dr. Dennis Goodman. I'm a clinical professor in the Department of Medicine and Cardiology and Director of Integrated Medicine. I'm delighted to bring you our series, our monthly Heart Health Lecture Series, and we have a very special guest for you this week, which I'll be introducing her shortly. Next slide. How do you ask questions? You go to the QA. I think you all know this now, and you can ask questions along the way. I'll be fielding them during Dr. Hausvater's lecture, but I've already received many questions, and I've got them ready. So not to worry, those of you who've already sent in the questions, I'll be tackling most of them if they're not covered during the talk. Next slide. So these are our upcoming webinars, all about high blood pressure on Wednesday, March 22nd, the environment and cardiovascular disease, April 19th, and improving your health through your gut microbiome on Wednesday, May 10th, 2023. So please sign up for these, and we look forward to seeing you. So we've had over 50 lectures since we started this in 2015. And as you can see, Anya's made a beautiful slide of all the different topics that we've covered, including osteoporosis and stroke, meditation, diabetes, pollution, stress management, cholesterol, biofeedback, pre-diabetes. We've covered multiple topics, and we're now starting to revisit many of them because we're all about prevention, and we like to bring you up to date with the latest information and the latest studies and research. Next slide. So we have a lecture library. We're very proud of this. And most of the lectures are now on video, on YouTube. And there are over 30 videos that are available and over 85,000 views so far. So if you've missed a lecture or you'd like to hear one of the lectures again, you can get that on YouTube by going to our website, which I'll show you right now. This is how you get hold of us. Take your phone right now and take a screenshot of this to keep in touch with us. If you go to the first one, nyulangone.org/heart-health-lectures, you can sign up, you can get to the YouTube videos, and that's the way that you can keep in touch with us. You can also use our email or the Twitter address. Next slide. So as you know, I always tell you that I'm very focused. We're focused in our department on prevention, and we cover topics like nutrition, exercise and flexibility, stress management, and sleep. And as you can see, we're always covering one of the topics that are related to these 4 issues. And for those of you working on prevention, you have to tackle every one of these for your stool to be stable. And that means for you to be heart healthy. Next slide. February is American Heart Month, and the American Heart Association's Go Red for Women. And as you can see some of the pictures from our department, we always dress up and we put red on. We're very aware of heart health for women, and that is why every February we invite a speaker. We usually have Dr. Harmony Reynolds, who's been fabulous and terrific, but this year we have another terrific speaker. Next slide. And that is Dr. Anais Hausvater. She's a clinical instructor of medicine and a junior faculty member and research fellow at NYU Langone. She recently completed her clinical fellowship here at NYU. Dr. Hausvater spent 2 years completing a research fellowship as part of the American Heart Association's Go Red for Women, studying heart attacks in women under the mentorship of Dr. Harmony Reynolds. Dr. Hausvater has published numerous manuscripts on the topics of heart attacks with open arteries or MNOCA, Takesubos or broken heart syndrome, and spontaneous coronary artery dissection. Dr. Hausvater has a special interest in heart disease prevention after adverse pregnancy outcomes and recently received pilot funding to study sleep in postpartum women who have experienced high blood pressure, hypertension during pregnancy. Welcome, Dr. Hausvater. I'm delighted to have you, and we're so grateful that you agreed to give this talk today. When you're finished with your talk, I've got some questions for you for some of the topics that maybe you have or haven't covered, and we're looking forward to your presentation. Over to you.
Great. Thank you so much, Dr. Goodman, for the warm introduction. Can you see my slides okay?
Yes.
Okay, great. So I'm delighted to speak to you all here tonight about one of my favorite topics, which is heart health in women. If there happen to be any men in the audience, don't worry, there will be plenty you can learn here as well. My goals for this talk include telling you all about cardiovascular statistics, the 8 pillars of cardiovascular health, unique cardiovascular risk factors we must consider for women, including pregnancy-related factors and menopause, the connection between stress and cardiovascular disease, and we will end with a few slides on heart attacks in women, how to identify symptoms, and what you should do if you or a loved one are having these symptoms. So cardiovascular disease remains the #1 cause of death in men and women. This graph shows the trend in heart disease deaths over the last 40 years. The red line represents women and the blue line represents men. You can see that women used to have much higher death rates than men. And the good news is that we are starting to close this gap. But the bad news is that deaths in both men and women are rising since 2010. There are currently more than 400,000 women dying from cardiovascular disease each year. This is more than the number of deaths from all cancers combined. And in fact, it is estimated that a woman suffers a heart attack every 90 seconds in the US. Unfortunately, women don't necessarily know that cardiovascular disease is the leading cause of death. Every few years, the American Heart Association conducts a random survey of US women. In 2009, as seen in the white bars here, a small majority of women who were surveyed could recognize that heart disease was the leading cause of death. But we seem to have really lost ground, as here you can see in 2019, only 44% of women could recognize that heart disease was the leading cause of death. And trends are even worse among minority women and young women under 40 years of age. Unfortunately, the knowledge gap exists at both the level of the patient, but also at the level of the doctor. In this survey of over 1,000 women, 200 primary care doctors, and 100 cardiologists, the researchers found that only 45% of women knew that cardiovascular disease was the #1 killer. So this tells us we need to raise awareness about heart disease among women. So I'm very grateful that you're all here tonight, and I hope you'll share what you learned with some women in your life. They also found that nearly a quarter of women admitted to finding a diagnosis of cardiovascular disease embarrassing, as they associated it with having problems with their weight. So this tells us that we really need to do a better job at destigmatizing obesity and countering stereotypes with facts. And lastly, they found that even doctors have a lot to learn. Doctors reported that only 40% of routine care for women includes a heart risk check. Only 40% of primary care doctors admitted to making cardiovascular disease a top priority for women. And only 22% of primary care doctors and 42% of cardiologists reported feeling prepared to assess cardiovascular risk among women. So we really need to invest in education for both patients and doctors. Let's talk about cardiovascular risk factors. These are heart disease risks that we can control, unlike risks that we can't control, like genetics and age. These factors that the American Heart Association refer to as life's essential 8 make up a construct of the optimal cardiovascular factors for optimal health, and it includes 8 modifiable elements. So this includes healthy blood pressure, normal cholesterol, blood glucose, normal blood glucose, normal weight, eating a healthy diet, exercising regularly, smoking cessation, and optimal sleep. Unfortunately, less than 1% of the US population as of 2022 meet all these criteria for ideal cardiovascular health. It's important to keep in mind that the prevention of cardiovascular disease involves multiple strategies that make up pieces to a puzzle. So we really need to control all of these factors to have optimal health. Let's start with blood pressure. So first, what is blood pressure? Blood pressure is the force against which your heart needs to pump to circulate blood. The top number is the systolic blood pressure, which is the pressure when your heart beats, and the bottom number is the diastolic pressure, which is the pressure between beats. So this pressure represents the amount of resistance your heart has to overcome with every beat. So the higher your number, the higher the heart the more the heart has to work. And remember that the heart is a muscle. So when blood pressure is normal, the heart does not have to work very hard. But when blood pressure is chronically high, which is referred to as hypertension, the heart has to work really hard to pump blood out to the rest of the body, and it can become thick, as muscles would if you were lifting heavy weights. 47% of US adults have high blood pressure. Blood pressure is often not associated with any symptoms at all for a very long time, which is why some people refer to it as the silent killer. Risk increases after menopause for women, and postmenopausal women have similar rates of hypertension as men. And women with hypertension have higher risk of heart attack, heart failure, and death from complications of high blood pressure than men. So who is at increased risk? Those with older age, those with a family history of hypertension, those who identify as Black race, those who are obese, those who have a high sodium or alcohol diet, those with a sedentary lifestyle, those who have insufficient sleep, and women who have had hypertensive disorders of pregnancy. Why bother treating hypertension? You might ask, why do we treat it if it doesn't cause any symptoms? Well, there are many complications in many different organs that can occur from longstanding hypertension, and these include stroke, vision loss, heart failure, heart attacks, kidney disease, and kidney failure. So treating hypertension leads to 35 to 40% reduction in stroke, 20 to 25% reduction in heart attacks, and 50% reduction in heart failure. People with high blood pressure live longer when they're treated with appropriate medications, and there are many, many different medications that treat hypertension. So if you have a side effect to one, there are many others we can choose from. It's important to know your numbers. So let's review blood pressure categories. So normal blood pressure is less than 120 systolic. Remember, that's the top number, over less than 80 diastolic, which is the bottom number. Elevated blood pressure is between 120 to 129 over less than 80. Hypertension stage 1 starts above 130 over 80, and stage 2 hypertension starts above 140 over 90. And it's usually at this level that we need to start medications. If your blood pressure is higher than 180 over 120, this is considered a medical emergency, and you should call your doctor or go to the emergency room. What can you do to lower blood pressure in addition to medications? Lifestyle interventions that are helpful include weight loss, healthy diet that is low in salt, so less than 1,500 milligrams per day, increased dietary potassium, increased physical activity, and decreased alcohol. Let's talk about cholesterol screening. Who should be screened for cholesterol? All adults. Adults should be screened at least every 3 to 5 years, and screening should start as early as possible. Lifestyle modifications that are important for cholesterol include weight loss, exercise, and dietary changes. And it's important not to just look at your total cholesterol, but at the bad cholesterol, which is the LDL. So let's talk a bit more about bad versus good cholesterol. So LDL is the bad cholesterol. LDL builds up in the arteries and causes plaque to form. Higher LDL increases risk of heart attacks, strokes, and other health problems. So the lower, the better. So we say that anyone with heart disease should aim for an LDL less than 70, but studies show that really you can go wrong no matter how low you go when you have heart disease. HDL, in contrast, is the good cholesterol. HDL helps remove bad cholesterol from the blood, and it brings it back to the liver where it can be broken down. So we want high HDL. Lp(a) is a newly identified genetically inherited form of bad cholesterol. It's a large lipoprotein molecule like LDL, and it sticks to the blood vessels. And it's a marker of high cardiovascular risk. Why do we treat high cholesterol? Atherosclerosis is the buildup of fatty deposits in the heart arteries, which we call plaques. Plaques are made up of bad cholesterol, and they can cause inflammation. Some plaques are more vulnerable than others, and these can be like a raw egg, which can rupture, leading to clotting and blockage of the arteries, which is what causes a heart attack. So many people ask, how do I get rid of plaque or make plaque go away? Unfortunately, there's no great way to actually get rid of plaque entirely, but our goal is really to treat cholesterol and stabilize the plaques that are there. So in essence, our goal is to go from a raw egg to a hard-boiled egg, which is much less likely to rupture. So treating cholesterol with weight loss, healthy diet, exercise, and cholesterol-lowering medications like statins make plaques more stable. So turn them into a hard-boiled egg. How do we actually calculate your risk? When you see your doctor, what are they actually thinking about? So this is a risk calculator that we use all the time in primary care and cardiology called the ASCVD risk calculator. And it essentially gives us an estimate of your risk over 10 years of developing atherosclerotic heart disease, including heart attacks and strokes. So as you can see here, it takes into account many factors, including your age, your sex, your race, your current blood pressure, your cholesterol, whether you have diabetes, whether you are a current or former smoker, whether you're already on treatment for hypertension, whether you're already on a statin, and whether you are on aspirin. And the number it gives us is this top middle number here. And what do we do with this number? So if the number here is more than 20%, then you absolutely should be on a statin or a cholesterol-lowering medication. Statins are one of the most effective ones that we have. If your risk is between 7.5% to 20%, then you're in an intermediate range category. And that's when we think about whether you have any other factors that are called risk enhancers that would push us towards wanting to treat you sooner. And then we might also consider more testing. So what are these risk enhancers? This is the full list of risk enhancers from the most recent guidelines, but I wanted to draw your attention to conditions that are specific to women, including adverse pregnancy outcomes like preeclampsia, as well as premature menopause, which we'll talk a little bit about. We might also decide to do some further tests to decide whether we should start a cholesterol-lowering medication, particularly if your risk is based on that calculator is in the intermediate range and you don't have any symptoms of chest pain. So a coronary artery calcium score basically looks at the amount of calcium in the arteries that feed your heart. Calcium likes to stick to areas with plaque, and it lights up brightly on a CT scan, so it's very easy to detect. This is a very low radiation CT scan. And a calcium score of 0 tells us that your cardiac event rate, at least for the next 5 years or so, is quite low. So we feel better about holding off on starting medications. In contrast, if your calcium score is high, especially if it's more than 100, you would be high risk, and that would really push us towards wanting to start you on a statin as soon as possible. What does this actually look like? So this is a real calcium score test, and this is a cross-section of the heart. And the bright white areas here in the middle are calcium that are attached to plaques in the heart arteries. So in this type of person, we would definitely want to start a statin. Let's talk about obesity. Obesity is defined by a body mass index, or BMI, more than 30. BMI is your weight in kilograms over your height in meters squared. Shown here is a map of the US, where you can see that really only a very small minority of states have a normal average BMI. And in fact, 24% of New Yorkers are considered obese. The good news is it doesn't take much weight loss to lower your heart disease risk. Weight loss of just 5% is associated with improvement in blood pressure, cholesterol, and glucose levels. Weight loss can delay the onset of diabetes, and in most people can be achieved by optimizing diet and increasing exercise. This will usually involve reducing caloric intake by at least 500 calories a day from your baseline. But there are some individuals who can't achieve sufficient weight loss by diet and exercise alone, particularly because obesity involves genetic components and derangements in brain chemistry. And in these cases, weight loss medications or even bariatric surgery can be hugely effective and life-saving. To combat obesity, we first need to combat the societal stigma that exists around obesity. The idea that individuals can fully control their body weight through choice, the idea that obesity is a self-imposed condition. This stigma leads to a lack of progress on a scientific level, whereby there's less effort going towards obesity prevention, less funding for obesity research, less coverage for obesity treatments by insurance companies, and less innovation around finding new therapies. And the stigma itself can be just as bad for a person's health as the disease. Stigma can lead to individual suffering, which leads to an increase in mental health disorders, increased binge eating and emotional eating. So paradoxically, the stigma itself can increase an individual's weight and can lead to increased sedentary behavior. So we really need to do better as a society and as a medical profession to move away from these outdated ways of thinking. Okay, let's talk about diet. The best diet for preventing heart disease is one that is full of fruits and vegetables, whole grains, nuts, fish, poultry, and olive oil, and can include alcohol in moderation. We want to limit sweetened drinks. We want to limit processed foods, processed meats, refined carbohydrates with added sugars like desserts, like cookies and cakes, saturated fats like butter and cream, tropical oils like coconut oil and palm oil. A lot of people think coconut oil is very good for you. It actually elevates cholesterol significantly. And you want to avoid regular intake of red meat. You want to completely avoid trans fats and particularly partially hydrogenated oils like we see in margarine. It's really important to read nutrition labels very carefully. Don't assume the food industry is interested in your health, and unfortunately, it's often the opposite. The good news is that people with diets consistent with this dietary pattern that I just described have about a 30% lower risk of heart disease, a 33% lower risk of diabetes, and a 20% lower risk of stroke. So here are my personal healthy eating hacks. The first is plan ahead. Stock your fridge with healthy foods and pack a lunch if you're going to work. Don't skip meals. So if you do, you might find yourself starving and willing to eat whatever is most convenient, which is unlikely to be a healthy option. Pack healthy snacks so you always have something when you're on the go. Same idea as before, just avoiding these spikes in hunger, which can lead to unhealthy choices. I would encourage you to stop dieting. Diets don't work long term. You really need to focus on just living a healthy life, which can sometimes include times of indulgence, and that's okay. Make more meals at home. Home-cooked meals are always healthier. You want to incorporate protein, healthy fats, and fiber with every meal. This will keep you full for longer. And you really want to focus on stress reduction and healthy sleep in order to regulate your appetite. Stress and sleep deprivation lead to overeating. So we really need to focus on these and ensure that we're set up for success. And the last tip I would have is to eat healthy as a family. Eating is often a social activity, so make sure the people you surround yourself with, either your family or friends, are also eating healthy. Okay, let's talk a little bit about exercise. Even small amounts of exercise reduce risk. The American Heart Association suggests at least 150 minutes of exercise per week, moderate intensity exercise, or 75 minutes per week of vigorous exercise. But I'm here to say that even 10 to 15 minutes per day has shown benefit. A lot of people think, a workout needs to be 45 minutes to an hour, and they just don't have that kind of time, so they just don't do any exercise. But I would encourage you, if you're starting from zero, just give yourself 10 minutes. Everybody has 10 minutes in their day, and 10 minutes goes a really long way. Let's talk about sitting. Sitting is deadly. Sitting too much can double your risk of diabetes and increase your risk of heart disease. Sitting too much actually shortens life expectancy. What are some ways to move more? One is you can consider a standing desk. Two is you can set an activity alarm. So, actually set an alarm on your phone if you are someone who has a desk job or works from home, and just get up and walk around every hour. Limit your TV time. Take the stairs whenever you can. Get off the bus or subway if that's what you use to commute, 1 or 2 stops early and walk to work or home. And consider if you're somebody who works and has frequent Zoom meetings or in-person meetings, consider taking these meetings while walking. Okay, so most people already know this, but smoking is one of the worst things you can do for your heart. Quitting smoking is really, really hard, but there's a lot of tools that can help, including various forms of nicotine replacement therapy and various medications that can help quit smoking. So if you are somebody who smokes, ask your doctor about some of these tools. All adults with obesity or more than 35 years of age should be screened for diabetes with either a hemoglobin A1C, which is basically a marker of what your glucose has been over the last 3 months, or a fasting blood glucose. Screening should occur every 1 to 3 years, depending on your risk. If you're very high risk, it should be every year. And it's really important you know your number. So a hemoglobin A1C between 5.7 to 6.4% is diagnostic of pre-diabetes, meaning you're at very high risk of developing diabetes and you already have evidence of insulin intolerance. Or a hemoglobin A1C more than 6.5% is diagnostic of diabetes. If you have prediabetes or diabetes, your doctor may consider medications like metformin to prevent complications of diabetes. And there are many complications that can arise from diabetes that is not treated. And these can include neurological complications like stroke, diabetic retinopathy, which can lead to blindness, various forms of cardiovascular disease like heart attacks, dental disease, disease of the kidneys, which can even lead to end-stage renal disease, peripheral vascular disease, which is disease of the arteries in your legs, diabetic neuropathy, so disease in the nerve endings that at your toes and your hands, which can then lead to foot damage. Okay, so this brings us to the 8th factor of the life's essential 8, which is sleep health. So disordered sleep is defined as poor sleep quality, short sleep, or very long sleep, or disordered breathing during sleep, like sleep apnea. Poor sleep is associated with increased risk for hypertension, obesity, diabetes, and even heart attacks. Too little sleep means less than 7 hours, and too much sleep is more than 9 hours. So ideally, I tell my patients get between 7.5 to 8 hours per night. Because too little or too much sleep is associated with cardiovascular disease. And the association between poor sleep and cardiovascular disease is unfortunately stronger in women than it is for men. So here are my tips for a better sleep. The first is the one that's hardest to do, which is turn off your screen at least 1 hour before bed. So don't look at your phone, don't watch television, read a book, meditate, do something else. Keep a consistent bedtime routine, which means try to go to sleep at the same time every night and wake up at the same time every morning, even on weekends. Try to avoid eating within 2 hours of bedtime. So try to have your last meal 2 hours before. Limit any afternoon caffeine. So if you're a coffee or tea drinker, stop drinking around 1 or 2 p.m. at the latest. Treat sleep disordered breathing. So if you are someone who has sleep apnea, there are treatments for that. And, you might need a CPAP, which can help you sleep better. And stress management as well, because stress is one of the leading causes of insomnia. It's important to know that there are risk-enhancing factors that are specific to women and are associated with an increased risk of heart disease in women. These include factors like early periods, use of hormone contraception early in life, a diagnosis of polycystic ovarian syndrome or PCOS, multiple pregnancy losses or miscarriages, adverse pregnancy outcomes, of which there are 5 which can occur during pregnancy, which increase risk, including preeclampsia, diabetes of pregnancy, hypertension diagnosed during pregnancy, preterm birth, so birth before 37 weeks, and delivering an infant that is small for gestational age. So that's less than 10th percentile in weight. And then there are some later factors like premature menopause or early onset menopause. And then breast cancer, which is much more common among women, can also increase risk related to chemotherapy and chest wall radiation. These factors, if they're present, would favor more intensified lifestyle changes, and in some cases, initiation of cholesterol-lowering medications. So there are 5 main adverse pregnancy outcomes that increase your risk, as I mentioned. And about 1/3 of women experience at least one of these in a pregnancy. And there was a recent study looking at over 2 million women who experienced pregnancy, and they followed them for 50 years after pregnancy, looking for ischemic heart disease events, which means chest pain events or heart attacks. And they found that adverse pregnancy outcomes were associated with ischemic heart disease even out to 50 years after pregnancy. So that tells us that this is really a lifelong risk factor. But the risk was strongest when the event occurred within 10 years after pregnancy. So what should you do if you have one of these risk factors that I mentioned? Well, you should tell your doctor. Don't assume that they will ask you. Make sure that the information gets into your medical record. Lifestyle modifications, like what we've talked about, healthy diet and exercise, might be more important for you than for others. And if you have more than one of these risk factors, consider seeing a cardiologist for preventative care. Okay, let's briefly talk about menopause. Menopause is loss of ovarian function or going 12 months consecutively without a period. The average age of menopause is 52 years, which means women spend about 40% of their lives postmenopausal. The menopausal transition is a period of accelerated cardiovascular risk. And women with early onset menopause, meaning less than 45 years of age, are at much higher risk of coronary heart disease, particularly those who went through menopause because of a surgery, an ovary removal surgery. And a high frequency of common menopausal symptoms like hot flashes, night sweats, mood changes, sleep disturbances can actually be associated with higher risk when compared to women who did not have a lot of menopause symptoms. What about hormone therapy? Is this safe? This is a very controversial topic with a lot of misinformation over the years, and unfortunately, this has led to a lot of women suffering with their menopause symptoms. Cardiovascular risk associated with hormone therapy really depends on the timing of when you start the hormones. Hormone therapy started less than 10 years after menopause is generally safe for the heart for those who don't have underlying heart disease, although it might just slightly increase your risk of blood clots and strokes. And this is when it's in the form of a pill. When it's in the form of a cream or transdermal or transvaginal, it's actually much safer with regards to blood clotting and stroke. Hormone therapy is contraindicated in women with known heart disease, including congenital heart disease. But if you're someone who's low risk, you're within 10 years of menopausal symptoms, you have a normal weight and normal blood pressure, then it's absolutely okay to take hormone therapy. So talk to your doctor about it. Let's talk about stress. Women are much more vulnerable to the impacts of stress than men, and clinical observations have linked acute and chronic emotional stress with cardiovascular disease. So perceived stress is the perception that the environmental demands exceed one's individual capacity to respond to those demands. And like I said, this is a much more significant risk factor for women. Women with heart disease report much higher stress levels than men, and they also have different sources of stress. Women tend to have caregiving stress, work and family related stresses, and these stresses can also lead to women delaying care. So women are less likely to present to care when they have symptoms of heart disease because of these stressors. Women also have a greater tendency to ruminate, which is a cyclical thinking where you're anticipating stressful experiences. And this can really prolong the stress response. Depression, similarly, is also more associated with cardiovascular disease in women. And this happens through a variety of different mechanisms, some of which are biological, including altering your autonomic nervous system, increasing inflammation, increasing stress hormones, and even increasing platelet dysfunction, which can lead to increased clotting. And it can also lead to adverse health behaviors like lower likelihood of compliance with your medications, less likely to have a healthy diet, less likely to exercise. What can you do to manage stress? This is much easier said than done, but there are some things that are known to lower stress, like regular exercise, healthy sleep, mindfulness training, meditation, including the meditation apps, which are very helpful, deep breathing, just a few minutes of deep breathing every day, avoiding known triggers of stress as much as you can, getting out into nature, as well as psychotherapy, particularly cognitive behavioral therapy. Okay, let's switch gears a little bit to talk about heart attacks. So first, what is a heart attack? A heart attack is an interruption of oxygen and nutrients to the heart muscle, which leads to cell death, and is usually caused by blood clotting on cholesterol plaque in the heart arteries, but not always. There are some heart attacks which are not related to closure of the heart arteries. But how do doctors decide if you're having a heart attack once you show up with symptoms? They usually will order an EKG and a troponin. The EKG is to look at your heart rhythm, and the troponin is a blood test which can show evidence of heart damage. What are the symptoms of heart attack in women? So chest pain is the most common symptom of heart attack in women, both men and women, but most people, or there's a thought that women don't have chest pain, and this just isn't true. Chest pain is still the most common symptom. Chest pain may start slowly. It might not always be like what you see in the movies where, you wake up with the worst chest pain of your life. It might actually be mild at first, but it usually lasts more than a few minutes. But women are less likely than men to have a heart attack, or less likely to have chest pain. So although it's still the most common symptom, especially elder women could have a heart attack without having chest pain. And women are also more likely to have multiple symptoms at once. So a woman with a heart attack might have chest pain, but might also have nausea, a little bit of shortness of breath, a little bit of lightheadedness and dizziness. And this can often lead to delays in diagnosis. What makes heart attacks different for women? Women with heart attacks are less likely to get diagnosed in a timely manner because of what I just mentioned. Women also have worse outcomes after heart attacks, especially young women. There's also a larger variety of causes for heart attacks in women. Less common types of heart attacks disproportionately affect women. So here are some types of heart attacks and heart attack mimickers that can occur. So the first one here on the top left, plaque rupture or erosion, is the most common type of heart attack, which is where you have that plaque that I mentioned that's like a raw egg that can rupture and a blood clot can form on top of it. There's also a kind of heart attack called coronary artery spasm, where you don't necessarily have plaque, but the muscles that are around the heart arteries can go into a spasm and can transiently block blood flow. Coronary dissection, or SCAD, is another type of heart attack where you can have a tear in the lining of your heart artery that can also cause bleeding into the artery and can close off the artery. Takotsubo syndrome, or broken heart syndrome, presents like a heart attack and is most common in women and is basically a transient form of dysfunction of the heart muscle. And then myocarditis is inflammation of the heart muscle, but can also present just like a heart attack. What should you do if you think you might be having a heart attack? My biggest advice is don't wait. Early treatment works best, and don't second guess yourself. If you're not sure, just let the doctor decide. The worst thing is you go to the hospital and it's a false alarm. That's much better than waiting at home with your heart attack and having more disability associated with it. Call 911 or go to your nearest hospital, but don't drive yourself because heart attacks can accelerate very quickly, and you can also have abnormal heart rhythms. Advocate for yourself. Know your risk factors. I just mentioned that women are more likely to be misdiagnosed. So if you're in an emergency room and you feel you're not being taken seriously, make sure you advocate for yourself. And ask for an EKG and a troponin check. Lastly, what can you do to help others? I just wanted to make a plug for learning and knowing CPR, because 380,000 people die of sudden cardiac arrest every year, and 88% of these cardiac arrests actually occur at home. So you can save the life of a loved one if you know CPR. And CPR has become much simpler than it used to be. All you have to do is what's called hands-only CPR, where you basically just push hard and fast at the center of someone's chest. And this can double a person's survival. So what are some important takeaways that I hope you've learned from today? The first is that cardiovascular disease is the #1 killer of women, and that better education is needed from both women and doctors. I want you to take away the 8 pillars of cardiovascular health, which include normal blood pressure, normal cholesterol, normal weight, avoiding tobacco, keeping a healthy diet, exercising, normal blood sugar, and a healthy sleep. I want you to know about the unique risk factors that affect women, including adverse pregnancy outcomes and menopause. I want you to know about the heart attack symptoms, and I don't want you to wait to seek care if you have any of these symptoms. And then CPR training is recommended for everyone to save lives. Thank you.
Thank you so much, Dr. Hausvater. That was fabulous and really one of the best talks I've heard on prevention and lifestyle changes, and really something that speaks to all of us in our prevention department. You did an amazing job of covering such a wide area, such a big area, and you discussed so many most important things that we need to think about. I received a lot of questions. So Anya, can you put the questions up? And I just want to also have a shout out for Anya, who does an amazing job making this happen. And thank you so much for all your help. So we're going to go through some of the questions, and we don't have a lot of time to answer them. So you can keep the answers very short, and I'll try to get to the questions that I've received as well through the Q&A. One of our favorite attendees is Stephen Howe. He always asks a lot of questions. I'll try to get to some of them, Stephen. But please forgive me if I don't, because I've got so many questions today. So you spoke about LPA and what can be done about it. And this was another question from someone who gives an example of the kind of question we get in practice frequently. Somebody say, let's take this person's 40, but say you've got a 50-year-old female with an LPA of 195, which is very high, an LDL of 120, which isn't bad, and a family history of cardiovascular disease. How are you approaching patients who are asymptomatic, but they have a family history of heart disease and they have a high LPA?
Yeah, it's a really good question. As I mentioned in my talk, LPA is a form of bad cholesterol. It's a genetic form of high cholesterol. And unfortunately, we really don't have any treatments to lower LPA specifically. And we don't even know if lowering it alone is helpful. But what we do know is that it's a marker of increased risk. So for example, for this person who's 40, who has a high LPA, moderately high LDL, but not hugely high, but a family history of cardiovascular disease, which is a risk enhancer, I would probably recommend a calcium score, a CT calcium score, to look for any calcium. If the calcium score was 0 in this person, then I'd feel much better about not starting a cholesterol lowering medication. But either way, even if the calcium score was 0, I would absolutely push for intensified lifestyle interventions like the ones I mentioned: Mediterranean diet, increased exercise, weight loss, etc.
I agree with that. And I think one caveat would be that maybe you would repeat the calcium scan 5 years later, just to make sure that this person's being monitored very closely. Next slide. And of course, minimizing all the other risk factors and normalizing them would be essential in somebody like that. Does diabetes affect your heart?
Yeah, absolutely. As I mentioned, diabetes is a really significant risk factor for heart attacks and strokes. And in fact, if you have diabetes, we have a very, very low threshold to start you on a statin to lower your risk.
Right. In fact, we consider someone with diabetes having the same risk as someone who's actually had a heart attack. And so it's so important for us to be aggressive. And obviously, from a prevention standpoint, the most important thing to do is try to avoid diabetes. And one of the most important ways to do that is to try to keep your weight optimal and a healthy diet. Next slide. Is there any research to suggest that a woman's systolic blood pressure should be 110 or less?
Yeah, this is a really interesting question, and I'm guessing this person really knows their literature well, because there was just a recent study, I think last year, which looked at many thousands of women who had heart events and looked to see what blood pressure thresholds increased their risk. And they found that women who had blood pressures above 110 had a higher risk. So perhaps that there is a different threshold for women than there is for men, and we know that women tend to have lower blood pressures. However, none of the guidelines currently suggest targeting a blood pressure that low. The reason being that there's a lot of risks if you are too aggressive with blood pressure medicines, and you can actually cause low blood pressure, which can cause, people to pass out. It can cause people to feel really terrible. So it's a little bit of a tough balance.
I also got a question from someone who said, what are the guidelines for patients that are older? So someone say over 65 years old, are you shooting for a low blood pressure? And I think the answer is very similar to what you just said, that when we try to get the blood pressure very low, especially in patients that are older, they're much more likely to have symptoms. And that we definitely want to avoid. But if someone's 70 years old, they got a pressure of 140/90 with risk factors, would you be more aggressive?
Yeah, absolutely. So, the recommendation is to get the blood pressure under 130 over less than 80. So for that person, I would definitely, increase their medications. But for an older person, we want to be really careful. As you mentioned, they have stiffer arteries. They're more likely to have orthostasis and, can have issues with passing out and things like that.
Okay, thank you. Next slide. Is hormone therapy helpful for postmenopausal women, and when should you start it? I think you covered that. You may want to just take 30 seconds to remind this person that it depends on a lot of things, but...
Yeah, hormone therapy is for symptoms of menopause. It's not used just for heart disease at all. But if you are somebody who's suffering with menopausal symptoms and you're within 10 years of the onset of menopause and you're low risk, then it's absolutely safe, and you should talk to your doctor about it. You shouldn't have to suffer with your symptoms.
Agree. Next slide. Is it helpful to start a statin at age 81? Because this person's been told that statin studies do not include an elderly population.
Yeah, so that is true that the studies did not include that population. And I think this is where we make the distinction between biologic age and chronologic age. So if you're a really healthy, robust 81, who's, very functional, who's exercising, et cetera, then we would absolutely want to be aggressive with, managing your cholesterol and your other risk factors. So it would be more of an individual level decision.
Okay, next slide. Do you recommend arterial screening for women who have long-standing hypertension? And by this, this person, I think, means carotid artery scanning. There are places that do this, that offer it to you in public space. You don't need you don't need a doctor's prescription. And would you recommend this for people who are asymptomatic or people who actually have high blood pressure?
Yeah, so if we look at the guidelines, there's no recommendation for routine arterial screening, meaning carotid or renal artery screening for those who have no symptoms. However, if you have symptoms, if you've had symptoms of a stroke or stroke-like symptoms, if we hear a brewery when we examine you, that might push us to screen you. But if you have no symptoms and your exam is normal, then it's not recommended.
Okay. Next slide. Are EKGs recommended as part of an annual physical? My primary doctor says I don't need it. I'm 67.
Yeah, you definitely can't walk into a cardiologist's office without getting an EKG. I think it's helpful to have a baseline, especially if you were to have something happen, a heart attack or something later, it's nice to know what your, baseline EKG had looked like. So I would recommend that everyone should get one at least once.
I agree with that. And I don't think you have to be 67. I think if you're 30 and you go to a cardiologist, you're going to get an EKG. And it's always helpful for us to have a baseline EKG on someone who is otherwise healthy. Next slide. What supplements keep the heart working efficiently? I'm going to give a lecture about this, and I'm not going to go into the details. I am someone who's integrative and holistic, and I do like certain supplements in certain patients. And I'll give you the 5 that I talk about and I use most commonly: vitamin D, magnesium, CoQ10, fish oils, and vitamin K2. But we won't go into that now. I'll give a talk about that, and we can get into further details about that. Next slide. I think we had a lot of questions about long COVID and how does COVID affect the heart. And we had a lecture about this, long COVID and the heart, by Dr. Katz, which was a fantastic lecture. So I want to just refer people to our YouTube. You can use your phone to take a picture of this, and you can go straight to the YouTube, or you can go to our website, nyulangone.org/heart health lectures, and you can find that lecture. So before we end off, I am going to just try to run through some of the questions that I've got during the talk, just to be fair to people who are taking the trouble and the time to ask us questions during the lecture. So Stephen Ho always asks me a lot of questions. If we can keep the answers short, and we can see if we can get through some of these and ask some other questions. So what specific blood test do you suggest for a woman? And he gave some examples: troponin, T, LPA, triglycerides. Is there anything else that you would think is routine? I think we're talking from a cardiovascular standpoint now. Of course.
Yeah, so my routine screening, if I'm seeing a woman just for cardiovascular risk screening, I would recommend a routine lipid panel. Everyone should have LPA checked at least once in their lifetime. And I'll usually check a hemoglobin A1C for diabetes screening. I would not check a troponin routinely if someone's completely asymptomatic. And the lipid panel, I should mention, includes triglycerides.
Okay. Is there any indication that LPA and LDL can cause aneurysms and inflammation in women's arteries? Any role of the MMP9 matrix metalloproteinase protein? I don't know if you're checking that. I know that it's one of the markers that can be checked, which can indicate plaque progression or unstable plaques, but it's certainly not part of routine clinical practice. But how about LPA and LDL for aneurysms?
That I'm not sure. The biggest risk factor for aneurysms is high blood pressure and smoking. So I'm not sure that I would check LPA and LDL for those indications.
Yeah, except I just think that if you do have a high LDL, you are likely to end up having atherosclerosis. It affects not only the coronaries and the carotids, but also the aorta. And so you would be, if you've got hypertension, at increased risk for aneurysms. And there is an association with high LPA and aortic stenosis, patients being at increased risk for that. How to prevent falls and syncope for postmenopausal women? I guess it is in some ways cardiovascularly related. And I think one of the most important things Dr. Hausvater mentioned is that sometimes the pills that we use for treating hypertension can cause hypotension and orthostatic hypertension, and we have to be very careful when we're treating patients with blood pressure pills that they don't create symptoms. Would you agree with that?
Yeah, totally agree with that.
From Fran Silverberg, my calcium score was 0. My cholesterol was a little high, about 215. I was told I don't need to be on statins. Does it do any harm to be on the statin? And would you feel comfortable, as you suggested, that someone like this could avoid a statin and just work on lifestyle changes and a healthy diet?
Yeah, I guess in part it would depend how old you are, because if you're very young, you might have a calcium score of 0 but have soft plaque that's not detected on a calcium test. But if you are someone who's high risk, we do repeat these tests every, depending on your risk, maybe 5 to 7 years. So I would have it repeated at that interval. And then I would do all of the lifestyle interventions that we mentioned to lower cholesterol.
Okay. Do patients who take Vascepa, which, as you know, lowers triglycerides, to take 4 grams of Vascepa a day, can you reverse arterial plaques?
I have not seen evidence of that, but maybe Dr. Goodman has more.
I think, again, that we don't know that it reverses. We certainly haven't got data that it reverses arterial plaques, but it can certainly lower triglycerides. And it has been, and it is indicated in people who have high triglycerides, and especially if they have diabetes. So I'm going to end it there and say, Anais, thank you. It was fabulous, and you really gave an outstanding presentation. For those who want to hear it again, as I said, it's on YouTube, and we look forward to seeing you at our next talks. I appreciate all of you checking in and signing in and keeping in touch with us. And we do put a lot of time and effort into providing you with these lectures in our prevention series. And we're always delighted to have wonderful speakers like Dr. Hausvater. Thank you very, very much for joining us. And
thank you so much for having me.
Heart Health Women's Heart Health Month.